Okay, terrible 10 point number 9 is that the aortic valve and the pulmonary valve are parallel. And this is something that should never happen. So if you ever see, particularly in a parasternal long axis or from the subcostal views, if you ever see the aorta and the pulmonary artery arising and they're parallel to each other and you can see them both very well in the same imaging plane, that is abnormal. And that is telling you that the orientation of the pulmonary and the aortic outflow tracts are not normal to each other. So you can say the same sort of thing when you're looking in parasternal short axis, and if you see the en face view of the aortic valve and you see the en face view of the pulmonary valve in the same imaging plane, you know by definition that the orientation of the pulmonary and the aortic outflow tracts are not normal, and this baby has congenital heart disease. The details of that are a little more complicated than that, but that will at least tell you that you are definitely looking at something abnormal. And so what we think about our differential is different causes of abnormal outflow tract orientation. And the most common things that you're going to see in neonates are this entity called double outlet right ventricle, which encompasses a lot of different physiologic states, but really what it just means is that both outflow tracts are arising from the right ventricle instead of one outflow tract from the right ventricle and one outflow tract from the left ventricle. The other entity that you're going to see most commonly in this situation is detransposition of the great vessels, which is the typical transposition that everyone thinks of when they think of a cyanotic blue baby. And that's the situation where the aorta is coming off the right ventricle and the pulmonary artery is coming off the left ventricle. Another possibility that you can see is this disease called L-transposition of the great vessels, or you can think of it as ventricular inversion, which is another name that it goes by. And in that case, the right atrium is connected to the mitral valve, which is connected to the left ventricle, which is connected to the pulmonary artery. And on the other side, you have the left atrium connecting to the tricuspid valve, to the right ventricle, to the aorta. And so if the patient who has this ventricular inversion has no other heart defects, they're going to seem normal because all the blue blood is coming back to the right side of the heart, gets pumped to the lungs, and all the oxygenated blood comes back to the left side of the heart and gets pumped to the body. However, in many cases, babies with L-transposition will have other heart defects such as VSDs, ASDs, valve abnormalities that will make the child symptomatic from heart disease. So you may see L-transposition in the setting of other more complex heart defects. But again, the tip-off in that situation is that the orientation of the great vessels is not normal. You're going to see the aorta and pulmonary artery arising in parallel, and you're going to see the aortic and the pulmonary valves en face in the short axis views in the same imaging plane, which should never happen.